I said just Dr. Bala is fine, but that's okay. Uh, all right. So I was asked to speak about leadership before the lunch, and I thought that'll be dreadful. So it's good to have a lunch break and talk about this because this is such a dry topic. Having said that, why leadership? Why? Um, I've been a specialist probably around 24, 25 years now, but uh, we all assume that if you're a senior clinician, you're a good leader. And that's where your workplace also assumes that if you're a good clinician, if you're a great surgeon, if you're a good physician, great physician, we assume ourselves into a leadership position. And is it the way it should be? I don't know. I have no idea. But I think with my very limited experience is that I think leaders are born. And then you make up as you actually train yourself as you go. And all these theoretical models and training modules and things sort of shape you around, sort of chip here and there to make you a good sort of a professional person. But at the end of the day, it's an innate skill that you have. You're born with it and you acquire it. It's got a genetic code with it. And why I'm doing this? Because I've been appointed as a medical co-director for the District of Population and Public Health in my district, the Illawarra and Shoalhaven district, which has got about a population of about 500,000, and it's got about 9 hospitals there. So based on my wide experience clinically, and also I've done a couple of leadership qualification, graduate certificate in health education and training, and with a good interview skill sets that I have acquired through talking to different people in YouTube and all that stuff. So I've got the job, but then I felt, look, am I doing justice to myself and to the position? So I thought I'll apply for the doctorate program. And I applied for the doctorate program for the population and translational health, which is through the Campbell University in North Carolina. I'm doing the course as we speak. So I thought this would be a great opportunity to practice my skills and also share my knowledge, the little what I have acquired and known over the years to you guys. And of course, some of you may already been in the leadership position. I know she's in a very, very high position, what she's in. She's in a leadership skills, and I know you've been sort of quite. So we all have our own skills in terms of leadership, clinical position. So, and we have our own style. So there's no one particular style that's good, but the recent terminology about being an adaptive leader has sort of emerged as a bit of a very fancy leadership style. So what is adaptive leadership skill? So it's a model that leaders use to encourage people to adapt in order to face and deal with the problems, challenges, and changes. So we all know that leadership skills are of different types. We have an autocratic leadership style where it's top to bottom. Nobody says anything. It's just that I say and you listen. That model exists. You have a transactional leadership skill, which is everything is about, I would actually negotiate with you something for the benefit of it, and you give me something back. Is a transactional leadership. Then you've got a distributed leadership, where you basically make sure that everybody gets to play their part and make a decision making, is a distributed leadership. Then you've got transformational leadership, where you actually empower someone to be a leader and co-design and co-manage with you as a transformational leadership. Then you've got the adaptive leadership skills. So there are different types of leadership, 5 different types. So you can choose which way you want. But knowing that healthcare organizations, as dynamic it can be and as complex, it's not static, it's very, very dynamic. So can you use transactional? Can you use autocratic? Especially in our physical medicine and rehabilitation, and with multiple stakeholders buy-in, you need to really get their buy-in, and especially with the consumer participation and things. Can you really use transformational? To be able to be transformational, you need to have the key stakeholders to have been in the same kind of a mind frame as you are. So can you use that? Probably not. You can't have a dictatorial leadership skills. So you're left with kind of a distributed leadership. Yes, it's an option if you want to be a very, very good healthcare leader, or an adaptive leadership. So the main activities of the adaptive leadership highlights the leader's behavior. So you need to be prepared to change your behavior as who you are as a person, at least at the outset. So because there will be a dynamic situational change, and recently we've had this problem. I was appointed as a medical co-director on the 1st of August, and we had a scabies outbreak on the 5th of August. Now, I'm actually a rehabilitation physician for over 25 years, completely forgot what scabies was. That's not my area. Had no idea. And then I had another co-director, but he's a non-doctor. And we have to come up with this plan of health risk assessment and disaster management. I said, wow, I'm in the deep hole here. What do I do? And then my chief executive, along with the director of medical services, they're expecting the population health. So our unit, population health, has got Aboriginal health service, multicultural health service, sexual health services, and the public health unit, which actually oversee the public health unit of the entire 9 district hospitals and the population, and alongside women's health and pediatric health. And as part of my medical co-director position, I'm going to oversee the population health, the public unit, and the sexual health. Well, that's my job. So what I suggested was I need to make, and I was actually kind of put under pressure that I have to do something to make these people know that I'm worth it. This is something that you go through when you actually get appointed as a director. Maybe when you are many years ago, maybe, I don't know. I mean, this is what my emotional feeling was, which I'm happy to share. And I'm not, feeling bad about sharing it. So when you're appointed as a director from a clinician role to a very senior management role, you feel a bit guilty. Look, am I doing the right thing? I want to show them that I can do something, I don't want to disappoint them. And damn, this scabies outbreak came. And I have no freaking idea about scabies. And I have been back and read about scabies and about what the spread is all about, permethrin cream and all that stuff. So I decided, you know what, I'm going to prepare a PowerPoint of how I do the rehabilitation in terms of PowerPoint, what needs to be done. And I'm going to give it to the committee and see what happens. And it was at 11:30, a bulb went in. So I thought I'd prepare a PowerPoint on how to manage a scabies outbreak using my knowledge on my previous experience, but then translated into the scabies management is identify, manage, prevent. So 3 catchwords: identify, manage, and prevent. So 3 catchwords, what you need to translate to penetrate into the general practitioners is that they don't have time for your theory. They don't have time for your nonsense. They want to see something very catchy, quick, what I need to do as a consumer. So identify, manage, and treat. So I had 4-5 slides, and then I submitted to the panel as to make them known that, look, I have done something. So that was well received. Oh, there you go. You actually contributed something. And I've learned from my chief executive in terms of how an adaptive leadership should be. So essentially what she did was, in my opinion, she's an excellent leader. And I was telling Eliza why females actually are good leaders. And it's a research-based evidence why females are good leaders than men. And we should not be ashamed to accept that. Trust me. Because in Melbourne, one of my colleague, a South African colleague, but of Indian origin, he actually did this extensive work of body of work. And he has become the corporate engineering advisor. And he actually gives the talks internationally now to see how corporate management can be effectively managed. And he actually has proven statistically that why female managers are better than men because of progesterone. Can you believe that? Excellent. So, and progesterone is actually quite effective in brain injury. So patients who have actually severe traumatic brain injury, they seem to have an downgraded progesterone. So there are some studies showing that if you actually progesterone actually helps with the brain recovery. So that's deviating, but that's one of the topic I thought I'll share So my chief executive actually gave a very good example of the adaptive leadership in terms of what's the task, what's the situation we have, what's the task we need to complete, and who needs to be delegated, and how do we operationally do it, and how do we monitor it. So essentially, we had these meetings along with my slide that I have prepared. It gave me a very good learning, steep learning of how we effectively manage this scabies outbreak within a span of 4 weeks. And our cases went right down without any community outbreak. And we had this good experience with the COVID because we did manage very well in our district. So that's what I'm trying to share, is that the situational challenges puts you, and then you have a technical challenges with the digital technology, which you need to incorporate with your situation. And then the adaptive challenges with so many people around you, which needs to be taken into board. So the situational challenges, what are all the behaviors that you need to have? And adaptive. So get on the balcony if you want to be an adaptive leader. Identify the adaptive challenges that you need to undertake. Regulate your stress. Maintain a disciplined action. Give the work back to the people, which is the component of the distributed leadership I talked about. And protect the leadership voices from below. That's very, very important to have that. So the problems in the workplace or the community that are clearly defined with the known solutions can be implemented through existing organizational rules. And that's a technical problem. So everyone will have this organizational manual, the delegation manual. So that's, if I have a problem, I'll go into this manual and then I'll refer, okay, this is what it is. We have all these policies written. That's technical. Now, the technical and the adaptive challenges is where there's no set organizational rules to fix a problem. They will have guidelines, but are we clearly going through these guidelines? But we always modify a little bit on the personal level to fix the problem. So you adapt at every level without even you knowing it. And then you have the adaptive challenges where these present problems that are not clear-cut are easily defined. So neither the expertise of the leader nor the organizational procedures can address this. COVID is a classical example. COVID was a classical example. No idea. Leaders have no idea how to manage it. Doctors had no idea what to do. People were in panic. Everyone was saying, wear a mask, wear a mask. Can you believe that my district some of the people are still wearing, at least 5 to 10% of the people are wearing a mask, but no idea why they're wearing a mask. No guideline. So you need to adapt to the situation. So what had come out of the COVID are telehealth flourished. Distance telehealth, regional health, digital health solutions incorporation, people moving from Sydney back to Wollongong and working from home, housing environmental changes. The environment became very green. People living in Sydney couldn't buy their houses, so they moved to Wollongong, and they could actually work from Wollongong, which is about 90 km from Sydney, much better. So the Sydney population actually moved. That actually de-stressed the Sydney people. We've got property prices going up. So there's a much of an environmental shift, climate changed, less cars on the road, more green, work from home flourished. So how we have adapted very efficiently from bottom up. So step away from the conflict without dissociating from it entirely. So if we have a problem, for example, with the scabies, we know that there's a conflict. I mean, it's a problem. Conflict is not the right word, I suppose, but this is more an operational word. So look at the bigger picture to get a full understanding of the problem and identify the challenge that you need to make. So pinpoint the problem, differentiate between the technical I'm talking about is the procedural manual based versus the adaptive challenge. Because none of these procedural based, the technical challenges were used with the scabies. Scabies we can use it for, or, the infection control. So the hand wash and things, that's all in the policies and procedures. But you need to penetrate beyond that to the community, to those key stakeholders, to the GPs, how to manage it. Similarly to COVID. COVID was a different, a much more bigger global adaptive challenges we had. You need to regulate your stress. In this situation, I was stressed because I was 1 week into this position. I want to prove my worth in that position. And I was trying to work out, oh my God, Now, what do I do? So I was stressed and I didn't know how to manage it very well, my stress level. So I was working a little bit extra hours. Reflecting back, even 1 month, I'm a little bit more confident now versus the first week of August. Now I could have regulated a bit better. And this doctorate program is giving me a little bit more confidence as I go. So I'm in 4 years' time, and hopefully that I'll do more justice to my work. But I can say that now I'm a little bit confident more than what I was before. So distress management is key, and a disciplined action. Because sometimes when you actually email, see, this is the difference between a clinician and a leader, right? Which is what I found in my experience. As clinicians, we pick up the phone and I can talk to my surgical colleague, orthopedic surgeon, first name. Hey, John, look, this is Vaidya. We've got a problem here. Do you mind? We do that. That's what we've been taught, right? Organizational leadership. Although we talk about adaptive leadership in situation management, but when it comes to the personal level, it's hierarchy based. I didn't know that. So I was talking to the chief executive, emailing her and then ringing and all that stuff. And then I get an email saying that, do you know that there's a tier 1 communication and tier 2 communication? You need to be writing to my EA, and then she will actually distribute the emails because I've got about 300 emails to answer. I said, wow. As a clinician, I'm not trained like that. I can talk to any of the head of the department, and that's how we doctors are. You probably know that. We just pick up the phone. We just talk to the doctor's colleagues. Yes, the surgeon wants to talk. They will talk to you, or they won't talk to you, but you can leave a message. But manager, they are different breeds. They talk about adaptive leadership when it comes to a situation, but when it comes to a person, they're different, which is what I have learned, at least in Australian setting. I don't know about the American setting, but at least in Australian setting. So now I've decided, see, this is what you're adapting. So I'm clearly adapting to the communication style that they wanted me to do. So I only write to the EA of my executive directorate. I stopped emailing her directly. No. And then she writes to me directly, but I don't email her directly. I email her EA. So she's allowed to write to me, but I have to write to her EA. This is an unsaid kind of the change as from a clinician to a manager. Behavior change is different, which I'm learning. So I am adapting myself. And so I need to be very disciplined in what I do within that work and give the work back to the people, as we all do. It's a more distributed leadership component. And protect the leadership voices from below. So because you not only distribute the work to the people, but you need to make sure that their opinions are heard. So which is more consumer satisfaction survey, consumer feedback survey, key stakeholders buy-in, to make sure that we keep all the consumers and the key stakeholders fully engaged, because we all know that clinicians engagement. Does anyone know about the medical clinician engagement framework? There's a new topic, there's something come in the last 24 months, I think 12 to 24 months, called as a clinician's engagement. If you wanted to have a good outcome in your healthcare organization, right, you need to have something called as clinical engagement of doctors. It's like any other profession. If your clinical engagement, if your doctors are not engaged in the work that they do, then your outcome measures or your success is questionable. It will be. So the medical engagement and the clinical engagement is where you need to get the doctors clinically engaged in what they do. What competently what they're doing is different to what is clinically engaging and doing it. They're two different things. A doctor can be quite competent and he can be in his box doing things what he does well, versus a medical and clinical engagement for an organization is where he thinks about the organization when he does something and steer the organization for the betterment of not only his clinical work, but also he represents the face of the organization. And there are some evaluation tools that we use. So we used that in the Wollongong Hospital in terms of clinical engagement tool for all the doctors. So I've actually rolled out, every doctor should fill this tool in terms of where they say they belong in the hospital. because it's no point, because some of the doctors might say, I'm just working there, but nobody sees me. I don't care. I'm just doing my work. Especially when it comes to the visiting medical officers, we have this category where they do their public work for 2 days, and then 4 days they do their private work. They do the public work just for being a senior lecturer for University of Wollongong, just for the sake of doing it. But then, they mainly focus on private work. So how much are you really contributing to the organization? And what is the organization doing for you? It's both ways, of course. It's not just one way, both ways. So that would be interesting to see, that I have actually rolled out as a clinical engagement to see the main focus is steering them together. So the whole outcome here is, in terms of the adaptive leadership, is cohesion across various departments to work for the better outcome of the patient. That's what it means. So with this, I probably will conclude my talk. This is a quick thing about the public health unit, about the scabies outbreak I talked about, but happy to talk about leadership. As I said, I'm learning as I go, and I've got my own personality in leadership. So and I've sort of reflected on my leadership skills. I'm actually a distributed leader. And then now that I have to be more an adaptive, so I'm a very distributed leader, because looking at all these tools and self-assessment tools that I've actually administered to myself, I've actually identified what leadership I am. So I can empower people, do things, delegate things very well, and get things done, and put their position and then voice them and get them. But that's one component of adaptive leadership. When it comes to a situational crisis, you need to rise above the distributed leadership to the adaptive leadership. So you need to have that command of unidirectional command on top of the distributed leadership to be able to achieve that. So that's my aim, to do that over the next 4 or 5 years, hopefully. That's it. Any questions?